Good afternoon and welcome everyone to our Dental Care Town Hall, taking a bite out of inequality, universal dental care for Canada. I'd like to thank all of you for tuning in today. My name is Don Davies. I'm the Member of Parliament for Vancouver Kingsway and also Canada's New Democrat Critic for Health. I am broadcasting in from the traditional territories of the Coast Salish people, the Musqueam, Tsleil-Waututh, and Squamish people. And I'd like to thank them for their grace in allowing us to gather on their unceded territory. We have a very exciting next hour, maybe hour and a half planned for everybody. I'm going to be joined by four really talented, skilled experts who each have a unique body of information, perspective, and take on both the challenges of bringing universal dental care to Canadians and also some great positive suggestions for how we can get there. Before I get there, I'd like to do some thanks to some people. I'd thank my staff, in particular Ryan and Peter, who have set up this technical broadcasting today. I know that there's always a lot of wrinkles in setting this up, so I'd like to thank them for taking time on a Sunday to do so. I'd like to just briefly go over the format that we anticipate following today. Again, we have four speakers. I am going to open up the forum by giving some introductory remarks, and then I'm going to, one by one, introduce each of the speakers, who will have up to 10 minutes to make a presentation on their particular aspect of universal dental care. I know two of the speakers have some audiovisual presentations. One is a video, and I think one is a slideshow. So we'll be able to go through that information. And at the end of those presentations, we will then turn it over to you and open up the forum to your questions and comments and suggestions, and hopefully sharing your experiences with dental care and the absence thereof in Canada. So without further ado, I'll open up with my introductory remarks, and then I will proceed to introduce our first speaker. When Tommy Douglas came to Ottawa first as a member of Parliament for Burnaby Coquitlam, he understood that Medicare was a project that would transcend his lifetime. Although he played a pivotal role in securing universal coverage for all Canadians for hospital and physician services, he knew that the task of expanding and improving Medicare would fall to future generations. This is not just an aspiration. As with prescription medication, the omission of dental coverage from our universal healthcare system is both a pressing public health concern as well as a major social justice issue. I think many Canadians would be surprised to learn that the most common infectious diseases are dental diseases. Studies have also linked poor oral health to serious health conditions, including cardiovascular disease, dementia, respiratory infections, diabetic complications, renal disease complications, premature birth, and even low birth rate. And numbers cannot quantify the pain, social impacts, and economic losses suffered by those with untreated dental problems. Yet, today in 2021, 32%, perhaps more, have no dental insurance coverage whatsoever, and 6 million Canadians or more avoid visiting the dentist every year simply due to cost and the fact they can't afford care. Unsurprisingly, this hurts poor and marginalized Canadians the most. Canada's most vulnerable people have the highest rates of dental decay and disease, but the worst access to this much-needed service. According to the Canadian Academy of Health Sciences, 50%, that's half, of lower-income Canadians have no dental coverage at all, along with the majority of seniors over the age of 60. Indigenous populations have nearly twice as much dental disease as non-Indigenous Canadians, and income-related inequalities in oral health are greater in women than men. On an international level, Canada should be hanging its head in shame. We currently rank second last in public financing for dental care among OECD countries. Now, it obviously seems plainly deficient to have a public health system that provides care for every part of our bodies, except for our mouth. But this is the present state of Canadian Medicare. In our view, Canadians have waited long enough. Access to medically necessary dental care should be a right in this country, not a privilege. So we think it's time to roll up our sleeves and begin the work necessary to make this overdue healthcare service a reality for all Canadians. So I'm really pleased to be joined by four superb Canadians who are extremely knowledgeable about this topic and who will share some really fascinating information with all of us. And I'm going to start with Dr. Brandon Doucet. Dr. Doucet is a dentist who graduated from Dalhousie University in 2019. He started the group Coalition for Dental Care to highlight the inadequacies of our current dental care system while also promoting a more humane alternative. Dr. Doucet, welcome. Thank you for joining us today, and I'll turn the floor over to you for your comments.
Thanks for having me. I really look forward to speaking here. And what I wanted to talk about is really why I started the Coalition for Dental Care group. And in order to do that, I need to take a few minutes to kind of show how our current dental care is structured. So dental care in Canada, the way people access these services are primarily based on work-related insurance and out-of-pocket payments. So this actually accounts for the overwhelming majority of dental spending at 95%. And only a meager 5% of dental spending comes from government programs, so targeted government programs, either from federal or provincial governments. This is an even lower amount of public dental spending than even the Americans. And because dental care is so privatized in Canada, it has many of the same problems as the American healthcare system. For example, has very high prices, has lack of standardized pricing. Also, as Don has already mentioned, the people who have the highest need for dental care have the hardest time accessing care. So to put some numbers to this, over 1 in 3 Canadians lack any form of dental insurance, and 1 in 5 avoid the dentist each year because of financial constraints. And both of these numbers are actually on the rise. So if we're looking at before the pandemic, we could look at changes in the economy as a whole. And what we see is that there's a lot of older people who are retiring and losing their work-related benefits. And a lot of younger people are working increasingly in the gig economy, which provides temporary employment that doesn't provide benefits like dental insurance tied to their labor. So both of these numbers have been rising. And the financial crisis sparked by the COVID-19 pandemic has only made this situation worse. So people are becoming unemployed, they're losing disposable income, which means when they become unemployed, they lose their work-related insurance, and they're losing disposable income to pay for these services out of pocket. And when you don't have insurance, you're paying the whole amount out of pocket, which is a lot of money, and results in people focusing, they get treated much later on rather than going for preventative treatment and early intervention. So what happens when people struggle to access dental care is that they need to seek alternative means for pain relief, as Dr. Sheikh is going to mention later. And this has many effects. And neglecting oral health can have not just physical, effects in your mouth, but it has effects over your whole body because your oral health affects your overall health as well. And there's other aspects as well. You can imagine having a toothache that it's really difficult to sleep. It's difficult the next day to focus in school or work. Also, if you have missing front teeth or if you have visible decay, it's going to affect your self-esteem, and it's going to be much harder to find a job where you work in the public. all of these things kind of come together to get people stuck in the cycle of poverty. And it's a lot hard. It's very hard for people to break out of this. And the longer people have to wait to get dental care, the worse things get. Small cavities grow to the point where people get pain and infection, and people need to ration the funds in order to deal with that pain and infection rather than putting it towards preventative care or early intervention. So what happens when people wait late stage is, for one, it becomes more expensive to deal with emergency procedures. It's a lot more expensive as well to keep your teeth. And what happens is people more often have their teeth removed, which subsequently lowers their quality of life. There's actually a statistic from the Public Health Agency of Canada that I find kind of mind-blowing. And it says that 1.8 million Canadians are unable to chew, which is just that's so many people. You can't get quality nutrition if you can't chew. So to highlight this, the current situation is very bleak. And this is all with the fact that we have a safety net in place, but this safety net is wholly inadequate. And I'm going to highlight this in a few different ways. So even with our existing safety net for dental care with the targeted programs, there's still over 1 in 3 Canadians that lack any dental insurance. And as I've described, this number's rising. Also, many people who rely on these targeted programs are underinsured. So this means the programs cover very few procedures, with extractions being favored over saving teeth. Also, a lot of people relying on targeted programs struggle to find a dentist who will accept them, because these programs often pay very low fees in comparison to a private plan. And they pay low fees because they've been kind of withered away over the years, as these targeted programs are able to be demonized by some politicians as kind of free stuff. And it's much harder to demonize a universal program rather than these targeted programs, because when you try to attack a universal program, it's seen more as an attack on the society as a whole. So, just something to keep in mind there. So the problems in the picture I've painted for dental care in Canada so far is why I founded the group Coalition for Dental Care. And the hope is really that we can build momentum around a more humane alternative. In the simplest way I can put it, we want you to use your health card rather than your credit card to access dental care. So the plan we have with Coalition for Dental Care is called Universal Dental Care. And there's 3 main points around universal dental care. The first is universal insurance. We think you should always have dental insurance. I don't think you should lose your ability to go to the dentist if you become unemployed, if you retire, or if you leave your significant other and you rely on their work-related benefits. You shouldn't worry about not being able to go to the dentist. And when people have dental insurance throughout their whole life, they don't neglect care as much because they can always go for those routine things, and there's not a 5-10 year period in their life where they can't go to the dentist. Also, another important factor is public ownership of some dental clinics. The traditional private practice model has resulted in a lot of dentists setting up shop in cities, focusing on luxury and cosmetic procedures, leaving a lot of rural communities underserved. So public ownership is a really good way to meet the needs of those populations in a more effective way. So we think public ownership of dental clinics should be not just in rural communities, indigenous communities, but there's also a lot of other places like schools, long-term care facilities, and prisons as well. And the benefit of public ownership is that you can hire staff based on salary rather than the more expensive fee-for-service model. So it can treat these populations more effectively. Also, with public ownership, it allows us to maximize the use of what are known as dental therapists, which are mid-level dental providers that can perform routine procedures like fillings and simple extractions at a fraction of the cost of a dentist. So I get really excited when talking about dental therapy because it really opens up a window of opportunity to provide dental care for the population at a very reasonable cost. Um, and when we're talking about universal dental care, we need to put this in context of where we are as a society. And I'm going to take a moment here just to talk about inequality in Canada. Because I really think that a universal dental plan should be seen as a form of economic relief for the average Canadian. So I'm going to be citing some work from there's a investigation done by the Toronto Star and Corporate Knights that showed over the last half a century, our tax system has changed in a way to benefit the rich and corporations at the expense of working people. So corporations used to pay as much taxes as individuals, but in 1952, this started to diverge, and now individuals pay 3 times as much taxes as corporations, with banks and oil companies faring exceptionally well. And also, there's, place big companies are able to store money offshore and tax havens and things like this. This results in us losing tens of billions of dollars of tax revenue every year. And that burden is shifted onto individuals, which results in working class Canadians taking more of the burden of the tax load rather than the rich and the corporations. And the COVID-19 pandemic has only made this worse. So last year, Canada's billionaire class added $53 billion to their wealth. So given this grotesque level of inequality in our society, we need to tax the rich like we did in the post-World War II era during the golden age of economic expansion and use that money to pay for social programs like universal dental care. And that's kind of the final point I wanted to make. And I just want to say, if anyone is interested in learning more about our group, please check us out on Facebook, Instagram, or Twitter, or email us, and we would love to get connected with anyone who's interested in joining.
Thank you, Dr. Doucet. You've raised a lot of really important points, and I know that people who are watching will have a chance to ask you questions or to expand on some of the really important concepts you've raised. Next, we're really honored to be joined by Dr. Hasan Sheikh, who is an emergency and addictions physician at the University Health Network, as well as a lecturer at the University of Toronto Department of Family and Community Medicine. He holds a master's in public administration from the Harvard Kennedy School and focuses on using the emergency department to diagnose failures of our public policies. Dr. Sheikh, thank you for joining us today, and the floor is yours.
Thank you so much for having me, Don. I want to tell those of you who are watching a little story about a typical case that I'd see in my emergency department. So, I work in a large tertiary care emergency department. It's busy. And when I would go to pick up a chart on almost every shift, if not every week, I'll pick up a chart and the chief complaint will say, toothache, dental pain. And whenever I see one of those charts, I kind of, sigh, and I kind of dread going in to see that person, because I kind of go into these interactions knowing that I'm not really the best person to see this patient. And the story's pretty classic. I walk in and I see someone pacing around their emergency department room, usually holding their cheek. They're in a ton of pain. And before I can even get through the introduction of who I am and why I'm there, they're already saying, Doc, I need something for this excruciating pain. And the frustrating part is that I know they need to see a dentist, but also they know they need to see a dentist. And they knew that before they came to the emergency department. But they come because they have nowhere else to go, because so many people are without dental insurance. So many people have trouble accessing providers, even if they do have dental insurance, and the costs are just far too high. And so people wait it out. They just hope for the best. And they come to the emergency department when they really have no idea where else to go. And this isn't just a frustration for me, in the emergency department or for that individual person. The reason why this is so important is because oral health is part of your overall health. Don introduced a few associations that at the top of this, that poor dental care is associated with worsening, heart disease, worsening diabetes, low birth weight infants. And these are all things that I learned in medical school as associations. But the more I dig into this, the more I'm finding that actual poor oral health causes poor overall health. There's a causation there. And when we do provide comprehensive dental care, we actually find that deep cleanings can actually reduce people's diabetes. It can improve diabetic control about the same amount as adding another oral medication. And what we found is that when we provide good oral health care to people in long-term care facilities, it reduces the risks of aspiration pneumonia. And we know that right now we have a crisis situation in our long-term care facilities, that we're really not providing the type of care we need to in those facilities. And dental care is one more of those things that population desperately needs. The other thing that I've found, which was really surprising when I looked into it, was that providing oral health care can actually improve retention in treatment for substance use disorders, can improve drug abstinence, and can actually reduce homelessness. So we have this piece of our body that, just like the rest of our body, is a contributor to our overall health. And for some reason, we've taken it out of our healthcare system and treated it completely separately. So your oral health is intimately connected to your overall health, yet access is extremely poor. 1 in 5 Canadians say that they avoid seeing a dentist due to cost. And it means that we end up with a ton more visits in the emergency department and in our Medicare system. Estimates show that about 1% of all emergency department visits are for non-traumatic dental pain. And that works out in Ontario, at least, to about 1 visit every 9 minutes. So what's frustrating about this is that this system as we have it right now is failing most of us. It's failing our healthcare system. It's failing our individual Canadians, and it's leading to more expensive care at higher costs and worse outcomes. We are paying for this right now. We're paying with higher out-of-pocket payments. We're paying with, decreased wages in our workers because companies are having to pay high dental care costs, and we're paying for it with increased healthcare costs. And there's really no reason why we should be treating our mouths differently than we treat the rest of our bodies and providing universal dental care for everyone. So looking forward to the question and answer section because I could talk about this for hours, but I will turn it back over to Don. And thank you for having me, everyone.
Thank you, Dr. Sheikh. And it's funny when you talked about 1 in 5, we're hearing this figure come up a lot. 1 in 5 Canadians don't visit a dentist every year due to cost. That's 20% of Canadians. So that's a ballpark around 7 million Canadians. That's almost the population of Quebec. To put it in perspective, that's how many Canadians every year. It'd be like no one in Quebec pretty much goes to the dentist because they can't afford it. To put some color into that sobering statistic. Thank you, Dr. Sheikh. I'm now going to introduce Joan Rush. Joan Rush has a Bachelor of Commerce, a law degree, and a Master's of Law degree from UBC, where she focused on health law and ethics. She is a former Vice President Law for the Canadian Life and Health Insurer and a former adjunct professor in both the law and dentistry faculties at UBC. Joan received the 2020 Merit Award from the Canadian Association for Public Health Dentistry in recognition of her advocacy on behalf of Canadians with developmental disabilities who cannot access essential oral health care because of affordability, accessibility, or availability of dental treatment. So welcome, Joan. Thank you so much for participating, and the floor is now yours.
Good afternoon. Sincere thanks to Don and his office staff, Ryan especially, for hosting this discussion today. I'm grateful to have this opportunity to speak to you about the lack of access to essential oral health care facing adults with developmental disabilities. These are Canadian citizens who have developmental disabilities and cannot access essential health care. I'm going to start my conversation with a reference to the recent election in Georgia. Stacey Abrams, former Georgian gubernatorial candidate, tirelessly campaigned to increase the voting presence of visible minorities in her community. And when she was asked what inspired her to continue her voter drive for 10 long years, she explained that growing up as a Black girl in the American South, she felt her country could not see her, could not hear her. Well, I feel that people with developmental disabilities in Canada face that same problem of invisibility. Our nation does not see them or hear them, does not recognize or respond to their needs. This invisibility is especially true regarding their lack of access to essential oral health care to prevent infections, avoid pain, and to help them keep their teeth. I'm about to show you a short video, it's about 4 minutes long, to introduce you to some people who live with developmental disabilities. Across Canada, Canadians who have similar challenges to the people in this video face terrible barriers accessing essential oral health care. I don't want them to remain invisible to Canadian healthcare professionals or to our medical healthcare system. So I'd like to thank UBC for production of the video, that's University of British Columbia for producing this video, and Dr. Doug Johnston, former Chief of Dentistry at Sick Kids Hospital in Toronto and subsequently at BC Children's Hospital, for being our video spokesperson. After the video finishes, I'll make 3 short points about how Canada and our medical and dental professions can fix this problem. And I'll be pleased to respond to questions when Don opens the discussion to everyone. So please start the video, Ryan. Thanks.
We had, as many people do, quite good dental treatment for Graham and access to dental treatment when he was a child. But when he became an adult, his care simply fell off a cliff. There was nowhere to go where they had expertise, and certainly no prompt access to treatment.
I think that access for individuals with developmental disabilities is poor within the province. It's poor within Canada. We're not alone, and this needs to change.
From our initial transfer to adult care from the Children's Hospital to Graham actually receiving some treatment to alleviate pain was over 4 years. And by that time, he had a very serious infection. And so much decay in his teeth, it took years to deal with the problems.
For their dental, they only have like going for a general checkup. It's like 2 years. Like every 2 years they have to go. By the time they go there, the teeth is already rotten.
In my experience, there aren't adequate services or facilities to support people like Deb, and it would make a world of difference for someone like Deb or anyone else with complex health needs or communication issues, if they had one. Hey, Deb? Yeah.
No question that adults with developmental disabilities need our help. They need more than what they're getting right now. There's no question about that. These are individuals who often don't have a voice of their own, can't speak up for themselves, often can't identify necessarily what's wrong with them or express what is wrong with them to other people, including people as close as their parents and caregivers.
Even if my son is in pain, I don't think he can have ability to express himself. I guess he was traumatized from the first experience, and we could have avoided all of that.
How to respond to our kids' needs, because they are needs, they are not misbehaving, they don't want to do that. When they drool, when they hit their walls, when they hit their faces, it's not because they have the disabilities, because they could be in pain as well. So I'm hoping that there is something out there, there is a clinic, there is a compassionate, professionally and ethically constructed clinic with highly trained professionals that understand our kids. That will be awesome. That will give me a peace of mind.
It would be very advantageous if a program could be developed within the bounds of the Faculty of Dentistry, where they teach dental hygiene students, to have them become involved in care and to learn how to deal with patients with developmental disabilities.
It's the most awful thing you can imagine to watch your child in horrific pain. Nobody should suffer the way Graham did.
I think it would be amazing for her to have a place to go where her situation wasn't out of the norm, and people understood the importance of keeping teeth.
If there's a specialized clinic, I will feel much happier for my son, for better life. That's what I'm hoping for.
With the help of community, with the help of the dental faculty, dentists, physicians, anesthesiologists, all working together, we could make a difference.
This is a tremendous opportunity for us to make a real change in the lives of adults who have developmental disabilities by ensuring they can access specialized dental treatment promptly. It's something we owe and something we must do.
Help, teeth first.
Thanks, Ryan. Hello again. As mentioned, I'll make 3 points today. My first point is that treatment for persons with complex health issues must be based on need and not on the scope of a limited dental plan. The BC Dental Plan for adults is now over 30 years old. Government has not updated the list of covered treatments since the 1990s, and the plan does not cover many standard preventive treatments such as fluoride applications. Plan fees have been frozen since the early 2000s and are now less than 50% of the Dental Association recommended fees. The plan has low aggregate fee limit, and I'm told that other provincial plans are even worse. That, for example, Ontario pays even lower fees for dentists to treat adults with developmental disabilities. So to repeat, adults with developmental disabilities must receive treatment based on their oral health needs and not based on some limited dental plan. My second point, Canada's healthcare system, including our medical and dental professions, must recognize the special medical care needs of persons with developmental disabilities and provide suitable treatment facilities and services. So the people in the video that we just watched, they cannot stroll into a community dental clinic and ask for treatment. They need specialized care, but our medical system fails to provide facilities properly equipped for dental anesthesiology. Our dental regulators across Canada fail to approve dental anesthesiology as a specialty across the country. Only one province has approved it. Our dental faculties fail to train dental and dental hygiene students to meet the oral health care needs of adults with developmental disabilities. So in short, Canada fails to ensure that these individuals can receive prompt treatment for both preventive and acute oral health care. So to repeat, Our medical healthcare system must provide treatment facilities and services that meet the needs of adults with developmental disabilities. And my final point, access to oral health must be equitable. Oral health is essential for overall health, as the last two speakers have just mentioned, and therefore it must become part of our universal healthcare system. It will only be equitable if it is universally accessible. So it's unjust, discriminatory, and therefore unlawful for our healthcare professions and our governments to fail to ensure equitable access to essential oral health care for persons with developmental disabilities. In my opinion, Canada must incorporate oral health into our universal healthcare system to meet the essential oral healthcare needs of all Canadians, including our most vulnerable citizens. So thank you for listening. I look forward to hearing your questions.
Thank you so much, Joan, and especially for sharing such a powerful video that I think illustrates the issues that are facing Canadians with developmental disabilities in such a visual way. So thank you so much for that. Our final speaker before we turn it over to questions and comments, and by the way, anybody who's watching, please send us in the chat any questions or comments or observations that you have, anything you'd like to ask to the panelists. We'll certainly try to get those questions answered for you. So our final speaker is Tom Lange. Professor Lange is a health economist and research coordinator at the University of Calgary Cummings School of Medicine and the Faculty of Social Work. There, he coordinates an interdisciplinary team of social scientists to translate high-level research data into tangible options for health and social policymakers. Working with the School of Public Policy, Tom recently published a set of cost estimates and policy options for a national dental care program for Canada. You can follow Tom on Twitter for his perspective on emergent health policy issues and photos of his three-legged dog, he tells us, at Tom Lange YYC. So, Professor Lange, I turn the floor over to you. Thank you for joining us today.
Thanks, Don. And I should mention you might hear the dog barking in the background, so sorry about that. Thank you to everyone who went before me. I know I was going last, and I'll build on a couple of points that were raised, but also just want to say I'm a bit taken aback by the video. It is always it's very hard to hear those accounts. And I like to say, as health economists and policy analysts, we get very caught up in numbers, and I'm going to talk about numbers here, but I always try and emphasize to my colleagues and to anyone that reads our work, like there's people behind those numbers. There's real people, and there's real hurt. So when we talk about things like 1 in 4 Canadian, 1 in 5 Canadians can't afford dental, over 1 million Canadians can't chew, that's real pain, and it's abhorrent, especially in a country that values so strongly equitable public health. So I want to quickly touch on a point that Hasan raised about people going to emergency rooms and their doctors once every 9 minutes. My role in health economics is putting numbers to all this stuff. So I'm going to give you one. There was a study that was done in Ontario that estimated about $28 million is the cost that's incurred annually due to these visits. And as you mentioned, like, it's not the appropriate place to get care. So it really represents a $28 million waste in our public health system. That's your tax dollars just wasted. So there's this considerable waste in not providing good access to oral health care. And I want to talk a little bit about what was talked about in the last video, like access. We need better access. And access is a very multidimensional phenomenon. Today, we've been mostly talking about like financial access, but there are other aspects. So like who pays for your dental care needs? Is it all private? Is there some public help? Are there tax benefits to help for this? Like who pays and who provides that access? So I'm just going to ask Ryan to put up this first slide that I have here. I've got 2 slides I want to go through today. That's the second one. I think it's the one before it. I'll just start talking while he finds the first one. But essentially, you'll see it's a Venn diagram, and there's three pillars to access that I see. So I said there's financial access, which is who pays for the program, who pays for your dental. And as Brandon already mentioned, Canada spends very little on dental. So it's mostly made up of payouts from private insurance companies and then a vast amount of out-of-pocket. It's about 50-50 split in the private sector. But then there's this other aspect called physical access. So that's actually finding a place that is willing to see you where you live, so you can physically go to a dentist, and also, as in the video that Joan showed, a place that actually can show or can actually provide the services you need, especially if there's specialized needs. Because we know that there's this comorbidity around people who can't afford dentistry. They may also have other complex care needs as well. So that makes the cost of their care, their dental care, higher than the average. At the same time, too, if you are fortunate enough to get on the limited suite of public plans that we have available for dental care, one thing that we've noticed is that they tend to pay out a lot less than private plans. As Joan mentioned, like the BC dental plan has not been updated in 30 years. The reimbursement fee schedules are typically very little. So you either, if you're a dentist and your patient comes to you is on a public plan, they know right away that I'm probably not going to get as much as the other patient in the waiting room who's on a private plan. And as such, I'm either going to have to charge a lot more out of pocket, or knowing that patient is probably of low income status, because that's who we target our public plans to, they're not going to be really able to pay for this thing. So what's the ethical thing I do? Do I just shoulder the debt? Do I shoulder the loss as a provider? So what we've actually seen is we've seen survey evidence that upwards of about 30% or more dentists in Canada have actually purposefully reduced the number of public plan patients in their practice. So we're going to talk about, that's the overlap of financial and physical access right there. Let alone it's hard enough to financially access dental services on my own. The limited plan I have, I can't find a dentist in my area that's willing to take me. Now there's this third rung of access, and I, for want of a better term, I'm calling it bureaucratic access. And that is, as I said, the plans that we have in place, they are typically designed for low-income individuals, people on social assistance. And you need to prove you're eligible to get on these plans sometimes. There's an example of that, which is Alberta Health Service has a fee-reduced dental program, but you need to bring in your notice of assessment from your last tax year. There's been considerable research work done in this field, noting that most of the people that really need this, the most vulnerable and disenfranchised in our society, don't apply, like they don't file taxes. We don't have an auto file tax system. It's hard to do that when you're transient, when you're homeless, when you don't have a fixed address, when you're not computer illiterate, when you're not financially literate. It's an ongoing issue. To put some numbers again behind this, that in other areas, only about 3% of Canadians that experienced homelessness received the GST HST tax credit. And they're the lowest on the rung, so they should be receiving the highest rebate, but they're missing out on it. Only 40% of eligible First Nations families received the Canadian Child Benefit. So there really is this bureaucratic, barrier to access. So where the arrow is pointing right there in the middle of these three is really the complexity, and I think a real challenge that we have to face in terms of policy making in Canada. We need an auto file tax system, which I believe was mentioned in the last speech from the throne as a promise. I really hope that comes along. But going beyond what wasn't in the speech from the throne this time is dental care. We need to renew our responsibility as a public to provide and fund dental care, equitably and efficiently for those who don't have insurance. And there's a growing number of Canadians who don't have insurance. And I would also argue that it's really spiked with the pandemic and the loss of employment, because we know from studies in the States that a 1% drop in employment is associated with about a 0.6% drop in people having extended health benefits or any health coverage, because it's the States. So I anticipate that right now a record number of Canadians have no dental insurance. We can move to the next slide here. So what I did, as Don mentioned, I worked with the School of Public Policy to put out some cost estimates of what could potential scenarios and dental public dental programs actually cost. Because we've talked about, inequity, but the solutions to that inequity, in my opinion, haven't been very well researched up until now, at least in academic circles. So I came up with two proposed models. I call one the Dentalcare model, which is like Medicare, where it's first dollar universal coverage, all dental services with strong medical necessity. So not like over cosmetic procedures. And then the other option would be the Dentalcare model that I created, which is where it's just basically anyone that doesn't have private insurance, and people that are currently on like the public plan. So like if you're currently on like the NIHB, or you're currently on like a social services plan, it would be replaced by this one. And it also covers for children below the age of 12. So here's the cost rundown. And I often say you really need to pay attention to the net cost, which is highlighted. But obviously the gross total cost of covering dental services for everyone in Canada is a lot higher, right? This is in billions, these numbers. So 27.3 billion. Add some admin costs in to administer these programs. But then what I have in here is this thing called premium and copay offsets. I did this as part of an academic exercise to sort of ask, like, if we did direct cost sharing, which is important in health economics to, really sort of account for the risks of frivolous overuse or things like that. If we set those like annual premiums and the co-payment levels to the same level as you see in the private sector, but instead we exempted a lot of all the low-income individuals in the plan, so it would be a more progressive rate structure rather than regressive. What you see there is that there's more premium and copay offset in the universal Dentalcare scenario than there is in the Dentalcare, and that's simply because in the Dentalcare you have everyone in society in your insurance pool, everyone from the richest Canadian to the poorest. In the Dentalcare scenario, you're really only creating a model or an insurance model that's designed around people who don't have insurance. So statistically, those people are going to be more of those people are going to be of lower socioeconomic status and thus exempt from those high premium copays. So you rake in less. So at the end of the day, the net change in public spending, Dentalcare would really only cost about $6 billion nationally. Dentalcare costs about 7.4. So this to me has been a signal that maybe the single payer model in Canada could be extended to dental as it is in medical, and there is an efficiency argument just in terms of net cost change. So we can close the slide down, and I'll just I'll close by saying that there's a lot of there's a growing interest in public dental. And just the fact that Canada does not spend very much on it, and the issues are so devastating, where there's a growing evidence base around, oral health influences your overall health. So not covering it is a ridiculous inefficiency in our health system. But I stress, there's different ways of creating universal health options and a universal dental care policy. I like what the Coalition for Dental Care advocates for, which is, again, increasing both the financial access and that physical access, that side that Brandon talked about using, dental therapists. And maximizing our dental workforce is really key to making sure that not only do we cover it universally, but that we have enough supply to meet demand. So with that, I'll turn it back over to Don. Thank you very much.
Thank you, Professor Lange. Once more, I invite anybody viewing to, if they wish to, using the public chat function, to send us your questions. If you have any general questions or would like to pose a specific question to any particular speaker, or if you have any thoughts to share, please do so at this point. I'm going to, I've been sort of tracking the chat myself, and there's some other questions that have come up, I think, through some of the excellent presentations we've had. So maybe I'll start by posing some of those first. So Dr. Doucet, back to you. I wonder if you could tell us, expand a little bit more on the role you see other dental professionals playing in expanding service to people. We have this nurse practitioner model. Is there something similar that we could do in dentistry? And I'm also curious, you being a dentist yourself, what other dentists, feel about the lack of coverage of their patients, and maybe what the role of the colleges across Canada and the Canadian Dental Association can play in addressing this issue?
Sure. So there are definitely a greater role that the rest of the dental team, other than dentists, can play in providing oral health care to the entire population. This can take different forms, but one of the big ones that I wanted to focus on is what are known as dental therapists. So these are mid-level dental providers, kind of similar to a nurse practitioner's relationship to a physician. These dental therapists can perform many of the same dental procedures as dentists. So like fillings, simple extractions, all at a fraction of the cost of a dentist. And when we're looking at the cost for a dental plan, most of the cost is actually going towards staff, so the people who are providing the dental treatment. So if we can maximize the use of these mid-level providers, the tax dollars we spend on, it can go further. Because, for example, a filling could potentially cost $50 to $80 with a dental therapist, whereas with a dentist, they may want to get paid $200 for that. So if we can maximize the use of those dental therapists, our money can go much further. And it's really exciting. We actually had a dental plan in Canada that used dental therapists in Saskatchewan in the 1970s, and it was wildly successful. The need for fillings in children decreased by about half, and the need for extractions went down by about half because their teeth were so much healthier. And it's not just the financial barriers, as we've mentioned, it's also having a dentist in your community nearby. And, parents don't have to worry about taking time off of work. How do I get to and from the dentist? And, I work in rural Newfoundland. A lot of these places, there's not providers nearby. So I have patients who will have to drive an hour and a half, 2 hours to see me. I really think the dental therapy is very exciting. It can take different forms. So in 2009, the last dental therapy training program in the country was closed by the Harper Conservatives. And there's been calls to reopen the dental therapy training program. So there's different ways that this can take place. One of them is kind of a standalone thing as it was before. But there's also been calls to have dental hygienists be able to become dually trained dental hygienists, dental therapists, so they can return to school afterwards to learn, some of the added skills to take on these extra responsibilities. And I think that these practitioners, the dental therapists, are critical to meeting the needs of the populations that aren't currently served, particularly, say, kids in school, but also places like long-term care facilities. Having somebody there who can do fillings, cleanings, simple extractions, just routine care, it really goes a long way within the dental plan. And when a dentist does come in to provide care for these people, they can focus on more complex procedures like doing root canals or crown and bridge work. So I do think that these mid-level providers are essential to providing high quality dental care to the entire population. To go to the second part of your question, Don, about the role that the colleges can play in this, it's a bit of a tricky situation. I think they should be playing a much greater role to ensure every Canadian has access to dental care. But the way things are set up, they're really set up to represent dentists. So when we look at who was the biggest opposition to, say, dental therapists, it was largely dentists in organized dentistry because they saw it as a threat to their monopoly. If these mid-level providers could result in us only having to pay $50 or $70 for a filling, whereas dentists want to get paid $200 for it, they're going to do what they can to keep them out of the picture. And I think it's something that the group like Coalition for Dental Care can really try to hold some of these organizations accountable, because they do have a lot of power. They do have a lot of sway within society, in the public as a whole, and having them on board for a universal dental plan really goes a long way. But I think we have to do the legwork to make sure that they're held accountable.
Thank you. Joan, I'm going to turn to you for a moment. You mentioned that you felt that there was at least reasonable coverage for children that have developmental disabilities, but somehow or other that stops when they become adults. So I have a two-part question for you. My first part on that is, would it make sense to you just to continue the coverage and for those children with developmental disabilities once they obtain the age of majority? And second, in talking before we went on screen, you mentioned some other countries that maybe we could learn from, or who are doing a better job of providing universal coverage. And I think you mentioned South Korea as a country. I'm wondering if you could chat a little bit about that as well.
Thank you. My comments are brief, I guess, on the issue of children versus adults with developmental disabilities. In the video, I said that when people with disabilities become adults, they fall off a cliff. And I maintain that technical term, falling off a cliff. The fact is, we do offer very, very sophisticated dental clinics in many children's hospitals across the country. And so people with the kind of pediatric dental expertise that Dr. Johnston brought to sick kids, and he and his colleagues all trained as pediatric dentists, that is provided to children with exceptional needs. Let's put it that way. Every child has needs, but those who have complex needs was available for children. There's no similar clinic anywhere for a person who has a developmental disability, and if as an adult who graduates into adulthood. The view seems to be in the country that, fortunately for all of us, developmental disabilities naturally are all cured and disappear at the age of 16 or 17. So we don't have to worry about them any longer as people become adults. Of course, that's ridiculous, but there was really no specialized clinic by any means to go to. And we assumed that hospital care would be suitable, and it clearly was not. I am grateful to say that I do have access for my son now to very specialized care, a dental anesthesiologist in the city and a very, very expert general practitioner. But my circumstance is unusual, and it shouldn't be. People should not have to have such difficulty. And besides that, my son's conditions are not so medically complex that he can't be seen in a community-based general anesthesiology clinic, where many people like Deb, who you saw in that video, they have to be in hospital. They need to be near an ICU. The other point, though, on how other countries have done, I was making that point in connection with our pandemic. And the fact is, Canada, having dentistry outside of our public health system, therefore could not support dentists easily, and dentists could not be part of the solution to the pandemic. And dentists are exceptionally well trained from our shoulders up, and they would be very well qualified to have dealt with testing and, many parts of pandemic response. And instead, their offices closed. They've suffered financially. They couldn't provide even crucial dental care for a period of time. And we have such a poorly developed dental advisory system throughout our government function that, and the associations and even the colleges are, as Brandon mentioned, dedicated more to lobbying for dentist interests than to worrying about public health issues. So they didn't have advice on what they should do. How should they get all the protective equipment they needed? What did they have to do to open? And so they stayed closed for a very long time, and it had serious ramifications for them and didn't help Canadians at all. And they could have been, dental hygienists could have been testing. We could have done a lot. But they turned to, as again, I think Tom or Brandon mentioned that the Americans, even though we decry that their healthcare system, rightly so, is terrible, and we're fortunate to have universal healthcare, their dental system has developed beyond Canada's, being a bigger nation. And so they have more public health and they had more advice for their dentists. Our dentists were forced to turn to the Americans for advice on what to do to get ourselves moved forward. But places like South Korea, where dentistry is part of the public healthcare system, they just ticked right along. And they received the equipment they needed. They were part of the whole, now they didn't face the same crisis initially that some of us did in the rest of the world. But in general, their dental community was part of their overall healthcare response. And there was no break where all the dental clinics had to close. So does that answer your question, Don?
Thank you. It does. And it's interesting. I mean, when we think of the present COVID crisis, I would think that dentists and dentist office are among the most highly trained when it comes to infection control and sterilization and things. So maybe there's much more to be explored there in terms of how we can utilize those skills. Dr. Sheikh, I'm going to sort of rope you and Professor Lange in together. There was, I think Professor Lange talked about the cost to our system every year of people landing in emergency rooms for dental problems, and I think he pegged that at $27 million annually. We had one of our viewers, Peggy, was asking about what about further hospitalizations and I think more serious medical complications that occur because of a lack of treatment. So sort of a two-part. I'll start with you, Dr. Sheikh. What do you see when someone shows up, as you described so clearly for us, in the ER and they've got pain and they're holding their mouth? Are you seeing many of those people end up coming back and then going into, having to actually get a hospital bed? And what kind of further complications do you see from these people later on? And then I'll sort of switch back to you, Professor Lange, if you can sort of give us more broad numbers on what it costs the system for those secondary and tertiary hospitalizations and increased health complications that come from a lack of treatment off the bat. In other words, if you don't get the original care at the beginning, what does it cost our system later down the road? So I guess, Dr. Sheikh, from a practitioner point of view, how do you deal with that? And Professor Lange, from an economic point of view, can you sort of expand on that?
Sure thing, Don. So absolutely, as I was saying, people come to the emergency room knowing that they need to see a dentist, but they have nowhere else to go. And so they come in and I'm trained in some aspects of oral healthcare, but certainly not to the degree of a dentist. And I don't have the specific tools or skills to really do a lot of the dental care that's needed, even making the diagnosis. So oftentimes I've left kind of looking at the patient, looking at their mouth and sort of saying, well, as I thought, you need to see a dentist, might have something like a dental carie that needs treatment, or this might be an abscess. And then we're left having this discussion of, well, what can we do? Sometimes we're having discussions about antibiotics, which otherwise wouldn't be needed or would be needed a lot less frequently if people could see a dentist. And there are risks of those antibiotics, including, some abdominal aches, some diarrhea, but also as a community, we need to be worried about overuse of antibiotics and antibiotic resistance. And then we're, on the other hand, talking about pain medications. And for a lot of people, we're trying with Tylenol, Advil, but that's often not enough. And so then we left having a discussion about starting something like an opiate. And we're in the midst of an opiate crisis, and anything that we are doing that increases our reliance on opiate prescriptions, I think is something we need to look at. And I think the lack of providing the proper care at the right time in the right place is one of those things that contributes to it. And so it means that we're providing suboptimal care, we're spending a lot of money doing it, and we're not really getting good outcomes. And I'll turn it over to Tom to talk more.
Yeah, I mean, outcomes is very, as I'd say, the buzzword, because we're doing, what does our health system cover in the basket of the Medicare basket, as they call it, the basket of what is publicly insured and what is privately insured. And we claim in public health sciences that we do a lot of cost effectiveness analyses. We have not done that really on dental as much. There's a really good scoping review that was done, I think in 2016, so not too long ago, and it really pointed out that internationally, the literature on what is cost effective in dental is largely unknown. CAD, Canadian Agency for Drug Technology and Health, their evidence bundle that they have on oral health is very limited. I swear it's something like 30 papers, but they're not all cost effectiveness studies. They're just they're just sort of briefing statements, really. So there's not a lot there to guide us in trying to make sure that what we're paying for in our hospitals when it comes to oral health care is cost effective, let alone what we want to pay for in our limited suite of public plans. Because again, also as Joan mentioned before, remember BC's is over 30, their public dental plans over 30 years old, and there has not been a lot of evidence generated yet since then on good outcomes on dental. But coming back to the original point, I know that was a bit of a tangent I just went on there, but the costs of this, the cost of not providing the actual oral health you need, and then leaving it so long until it becomes so awful you need to go to the ER because you're in so much pain. What you, again, as Hasan mentioned, is you just end up with the last resort, which is prescribing pain medication. Maybe you will also be hospitalized for an overnight stay, depending on how advanced it is. The cost figure I cited before was really just looking at ED, emergency department use. So there's also more cost. I don't have exact figures on it, but there's more cost around going to your family physician, your GP. And we want to talk about the timing, the cost, not just in terms of dollars, but just time, wait times. This is emergency department wait times. This is primary care physician, office wait times. They're being clogged up with things where people should be going elsewhere. So that comes with a cost. There's a lot of spillover effects, and it's hard to quantify the exact costs. But I often say, I don't need a full study to be able to tell you the universal dental care saves money, because the negative impacts on whether it be on lost labor productivity, poor labor force participation, the cost of small businesses to try and provide dental insurance, and when they can't, then their employees are going to be the ones who are going to be ending up in the ER more often because they don't have access to dental. That's lost productivity. Even just the economic incentive that if we started to provide more of these extended health benefits like pharmacare and dental, that gives us quite a competitive business edge in recruiting companies from America. I remember when I'm out in Calgary, and I remember when Calgary was trying to, finagle Amazon to set up its second headquarters here. We can't, our mayor, Naheed Nenshi, campaigned a lot on, hey, we have universal health care here, so you don't have to pay that to your employees. well, you might still have to pay your dental, and we don't really have universal health care in that everything's covered, though. So we could do better that way. So there's a lot of economic benefit to this, and a lot of economic cost to not providing better public health care or better public dental care in our health system.
Yeah.
And just to add to that, Tom.
Yeah, please.
Thanks, Don. The one thing I want to bring up is there's nothing magic about the mouth. There's nothing that makes it suddenly follow completely different principles than the rest of our body. And so while we don't have, some of the kind of robust evidence that we might want, we have a lot of things that we can look at for every other part of our body in terms of how we provide medical care. And what we see when we compare, for-profit privatized care compared to something like a single payer system is we get, much better control of costs. The cost of seeing a physician is a lot lower to our system here than somewhere like the US. We get better coordination of care, and we get, a lot less administrative costs, and we get better outcomes. And there's no reason why that shouldn't be the case for dental care as well. And, this is exactly, one of the other things we find is when we, don't provide basic medical care for people and is accessible and affordable, people leave their medical care much later. They come in with much worse disease that ends up being much harder to treat, much more expensive. And that's the exact same thing that happens right now with our dental care system. And so what we, if oral health is part of our overall health, then we have to treat it like that. And we have to start to bring dental care into, and follow the same principles that we follow on the Canada Health Act for Medicare.
I think we touched on this a little bit, but when our public healthcare system was being developed in the 1960s, and there was a 1964 Commission on Health Services, I think I was surprised to learn as health critic that universal coverage for dental care and for pharmaceuticals, by the way, was recommended at that time. It was always intended that our public healthcare system should and would include access to necessary dental care services. And I was very surprised to learn that the reason given at the time for not proceeding was simply because it was felt that we did not have a sufficient number of dentists at that time. And I actually have some numbers here. They said in 1964 there was one dentist for every 3,108 Canadian patients, and the commission at that time projected that a ratio of 2,671 patients per dentist could be reached by 1981, and that would be sufficient to have enough dentists. Leaving aside Dr. Doucet's comments about maybe having more services provided for allied health professionals. But today, there's no excuse for that because we have one dentist for every 1,622 patients. That's according to the Canadian Dental Association. So we literally have twice as many dentists per population today as we did back in the 1960s. And the commission back in the 60s as well said that even though we didn't have enough dentists, they said that it was imperative to immediately establish a public system for children, expectant mothers, and public assistance recipients that could be scaled up as the resources expanded. And they said at the time that was one of the highest priorities among all of the proposals that they made. They also envisioned that by 1980, all children up to the age of 18 would be entitled to public dental services in Canada. So, this is not a new issue. In many ways, I think what we're dealing with is a half century of dropped public policy on something that was originally imagined. And I also wanted to make a point before I turn over to ask for your comments that I think this is one of those areas where it's getting worse, not better, because the way people get access to dental services now is, as we've commented, through job-based benefits. But with the increase in contract work, in gig work, in short-term precarious work, and frankly, just simply employers nowadays who simply are not offering extended benefits to their employees like they used to in the 1970s and 80s. We are actually, with every passing year, seeing fewer and fewer Canadians have coverage through their employment basis. You throw on that a pandemic like we had in the past year, where millions of Canadians were thrown out of work, who then lost their job-based benefits. And I think we're setting up a recipe for even worse problems coming in the years ahead if we don't get a grip on this. So beside it being a health imperative and a social justice imperative, I think there's a very strong economic imperative for this. So sorry for the long-winded soliloquy there. I think it's important to note, though, for people that this isn't a brand new idea, that there's some sort of complicated structural reason why we cannot provide comprehensive dental care through our public system, but rather it was always intended to be the case. And I think just successive federal governments have just dropped the ball. So why is that? Why, it seems absurd. All of us today, I think I can speak for all of us when I say it seems ridiculous that we cover our whole bodies and then we carve out this one little area and say, well, that's not part of our public health. It's self-evidently absurd. Why are we unable as a G7 country, one of the wealthiest countries on earth, with this history, why are we unable to make that logical expansion of our healthcare system? Joan, I think you had your hand up.
Thank you. I wanted to make a comment. I think it was probably in response to Hasan and Tom's points as well about the agency. But one of the differences I think that is important in how medicine and dentistry have developed because of that, or since the time of that sort of split where medicine became public and was subject to much more government oversight and dentistry did not, is that medicine in Canada is far more evidence-based, and we as citizens expect it to be, whereas there is no such obligation imposed on the dental profession. And so I use by example when I asked about the list of all the treatments that are, when your dentist talks about how they will charge only the Dental Association recommended fees from a fee guide. The fee guide is developed by the Canadian Dental Association, which is the lobby group for dentists. And there is a scientific group that sort of develops new treatments, but the association itself will not confirm that their list of treatments is all therapeutic. You're simply trusting your dentist that the treatment you're receiving is absolutely therapeutic. You might feel very comfortable with a dentist like Brandon, but if you walked into a dentist office in some place that you've never been, a big city, you're simply trusting that they are giving you dentist care, dental care that you need, and that the fees that are charged are accurate and so forth. Many dentists will say, and certainly have said to me, dentistry is private. I can charge anything I want. Nothing is more clear about that than in the province of Alberta, where Tom is. And we've had very little teeth, either federally or provincially, to deal with the issue of how they come up with their fees and guides and what services are included. So the Competition Bureau, utterly teethless and toothless, I should say, and said to Alberta dentists, you shouldn't even bother with a fee guide. That was a number of years ago, because it sets a lower limit and on prices and affects competition. And so they did away with it and made the fees go sky high. When Alberta was rolling in oil dollars, dentists could charge anything they wanted until the government finally stepped in to affect it. But we end up with services we're simply reliant on trust, where we don't have to feel that way in the world of medicine. Generally speaking, if you go to a doctor and they give you a service, you know that it is considered by our medical healthcare system and in each province's medical services plan to be therapeutic, and the cost what they're gonna pay for it is appropriate to the fees. So I think it's another reason why we have to step in, just to make sure we're getting treatment we truly need. Anyway.
There's a couple points I wanted to quickly jump in on to Joan's point. Like, yeah, like it is really profound how dentistry is kind of this black hole in our supposed evidence-based, doctrine in modern healthcare. And CBC did a really good marketplace investigative report a couple of years ago that they had one of their participants get checked first by a doctor or by a dentist that was with the Canadian Forces, and then they went to different dental clinics to get a diagnosis and a treatment plan, and the treatment plans varied widely. So not having any oversight is a huge issue, and this is another big. If we want to talk about waste, I know we've been talking about this is I'm talking about waste in the public healthcare system, but we're also talking about waste in just the consumer market. Are you actually getting good value for dollar? And that's what I kind of Hasan brought up before that. The mouth is no unknown region. We have a scientific basis of understanding what's good oral health care. And I'm not suggesting we don't. I'm suggesting that the procedures that we do for them, we don't typically investigate their marginal benefit next to the marginal cost of providing it. And that in there is our big missing piece. So when I did my report, a couple of colleagues who have been doing this work longer than me, and I completely agree with their assessment, is that and the criticism of my paper was that I wasn't very specific in what dental procedures would be included. Mainly that's because I'm not a dentist, I'm a health economist, so I'm not prepared to make that judgment call. But that comes out of the fact that there's not a lot of literature to say this is appropriate for public coverage. This is not. That is something that I really want to pull together a really cohesive research agenda with CIHR and the rest of the expertise in Canada and internationally, because we really need to build that evidence base. And the Canadian Association of Public Health Dentistry agrees as such, I would say, in their recent position statement that they provided to the Standing Committee on Health. Anyway.
I think something to add to your point as well, Tom, is that's something I see firsthand as a dentist is people coming in for second opinions, and they say, I went and got an opinion at this place and they told me I needed 7 fillings, and I'm looking in there and I'm not seeing 7 cavities. So the lack of oversight in these things really is a big problem. And I think most dentists do a great job. They're doing great work, but if we look the other way for those bad apples, I kind of use the analogy of police. So, a lot of police officers are trying to do an honorable job, but if we overlook the ones who do really horrendous things and don't punish them and don't hold them accountable, to some extent, we're accountable for their actions as a profession. So I do think that's a really important point to make. And to kind of circle back to what Don was mentioning, why we can't have a program like this, we need to remember that when Medicare was first implemented, the biggest opponents to it were doctors themselves. So with respect to dental care, I see this as there was a window of opportunity in the 1960s when universal healthcare was implemented. And I think to some extent, dentistry was just trying to say, we need to stay out of the kind of the crosshairs here. We're going to let physicians be the one fighting this battle. And if we avoid this particular issue, it's probably going to be a long time, or it's going to be very difficult to muster up that kind of energy again to have us undertake a big project like putting dental care under a universal healthcare system. And that's really what the Coalition for Dental Care is trying to do, is act as a counterweight to say, no, this is very possible. It's necessary, in having voices from the dental profession, but also from other people in the community as well, I think carry a lot of weight as to countering some of those narratives.
Hasan, did you have any comments on this?
I think Brandon's absolutely right. I mean, doctors were the biggest opponents of Medicare when it came in. On the day that Medicare came into effect in Saskatchewan in the 60s, I mean, almost all the doctors went on strike. And at this point now, especially during the COVID-19 pandemic, I don't think any of us would want to practice in a privatized system, right? So it requires a sense of leadership amongst our policymakers and our elected officials to kind of take that leap and say, this is what's best based on the evidence, based on what we're hearing from our constituents, that this is the way we need to go. And we're gonna, you know, we're gonna kind of fight this battle and make sure we get it over the line, because once we do, I don't think we're ever gonna want to go back.
Well, thank you for that. Well, I see that we're coming close to the hour and a half mark, so I think it's an appropriate place to wrap up. One thing a couple of closing comments I'd like to make is I think there's an immense amount of goodwill around this subject. I have been struck repeatedly by, whenever we talk about public dental care, the extraordinary reaction we get from the Canadian public. And I think that's for a few reasons. I mean, the numbers, as has been pointed out, are staggering. Basically we have at least 1 in 3 Canadians who doesn't have any dental coverage. That's about 33% of Canadians. That's probably 12 or 13 million Canadians. But also, of course, we carry this in our face. We didn't have a chance to explore the concept of stigma and how our teeth and our faces are tied to our self-image and our self-esteem and all of that. But I think it's quite clear that the Canadian population, I believe, would be very strongly in favor of ensuring that every Canadian gets access to the dental coverage that they need. I think it's a no-brainer when it comes to that. And I also think that I want to thank all the dentists and dental health allied professionals and all the groups that are working for this, because I think that at their core, everybody working in this field cares about their patients, and they care about the health of Canadians, and they want to make sure. I don't think anybody doesn't want to make sure that people get the necessary medical and dental care that they need. I think it really is a failure of public policy. And I think public policy, the answer to that is leadership. And I think we need leadership at the federal level. There was a question asked about what the New Democrats are doing about it. Well, we campaigned on it in our platform last time. I have moved a motion at the Standing Committee on Health in the House of Commons to initiate a study of public dental care. And I think we're generating some attention to this by trying to put it on the national stage. But I think we can do this, and I think we need the public behind us, and we need everybody who believes that the time is overdue for us to make this absolutely logical expansion to our public healthcare system. I want to conclude just by saying how honored I am to be joined by such outstanding Canadians and such knowledgeable experts as we're on this panel today. I'd like to thank them once again, Professor Lange, Ms. Rush, Dr. Doucet, and Dr. Sheikh, for sharing their expertise on really important pieces of this question. And I think it's really added a lot of information and important color to this picture that is needed as we move forward. I want to conclude by saying that this is only the beginning of our campaign on this. We want to continue to raise the prominence of the need for dental care for all Canadians. And I look forward to hearing any comments that anybody who's viewed this back. We will be, of course, making this available on Facebook, and we'll have more of these with the same experts we've had and others. So please let me know if you have any thoughts or comments or concerns. You can email or drop a letter without even a stamp required in the mail to me at any time. And I look forward to working together with all of these wonderful stakeholders and many, many people across this country to finally realizing Tommy Douglas's dream and the dream of many, many others to build a healthcare system in this country where everybody gets access to the care they need, regardless of their wealth or regardless of their social status, but as a matter of right of citizenship. So thank you again to my staff for setting this up. Thank you to all the viewers who took time out of their Sunday to join us today. And everybody, please stay well.